Good morning, everyone. My topic is necessity of neuroimaging in neuroophthalmologic cases, consensus and disagreement. There is no financial interest in any of the product or technique mentioned or discussed in the study. Neuroophthalmology shares high risk of life-threatening pathology than in other ophthalmic subspecialties. Neuroophthalmic signs are commonly the presenting features of intracranial space occupying lesions, and hence neuroimaging is frequently required to rule out serious intracranial disease and sometimes to rule in. However, there are significant medico-legal consequences to missed or delayed diagnosis when patients with serious neurological conditions present first to the ophthalmology. Consequently, personal experiences or expert opinion guide the decision regarding neuroimaging necessity, but at the same time, health economic factors highly influence the urgency of neuroimaging. As a result, imaging for neuroophthalmic conditions may occur less urgently than the requesting clinicians would like. Thus, urgency of neuroimaging in day-to-day practice in the health service, either being private practitioner or under government cover, is therefore determined by pragmatic balance between clinical judgment and pressure on the imaging services. The aim of the study was to get expert opinion of how urgently to request neuroimaging for neuroophthalmological clinical scenarios. Neuroophthalmologists were approached with list of 35 different neuroophthalmological clinical scenarios generally presented in the IOPD and asked to state how urgently they would obtain neuroimaging. There were 4 responses options. First, emergency, that is within 2 days, urgent within 1 week, observation after 1 month or at 1 month, and the fourth one was no need. Consensus was set at a prior level of 70% agreement. These are the list of the 35 clinical scenarios. The result was 18 out of 35 scenarios made the criterion for consensus. 3 of these were for emergency imaging. Of these 3, 2 were for presentation of third nerve palsy, namely both scenarios stating pupil involvement but in a younger patient. The third one was one scenario for which there was consensus on emergency imaging was downbeat nystagmus in 60 years old with 6 months history of oscillation. Consensus was reached for urgent imaging, that is within 1 week, for 5 scenarios. These were bilateral optic disc swelling with the recent onset headache in 25-year-old, asymptomatic bilateral optic disc swelling with drusen and reduced visual function in a 40-year-old, asymptomatic bitemporal hemianopias picked up incidentally by optician in a healthy 40-year-old, acute painful isolated Horner in a 40-year-old, horizontal jerk nystagmus with 6 months history of oscillations in 60-year-old. Consensus for the response category of observation was reached for 6 scenarios. These were asymptomatic bilateral optic disc swelling with drusen and normal visual function in 40-year-old, asymptomatic unilateral optic atrophy with mildly reduced visual function in a 50-year-old, picked up incidentally by opticians, suspected unilateral functional visual loss in a 20-year-old, unexplained bilateral central scotoma in 25-year-old, bilateral 6 nerve palsy in 65-year-old diabetic, sudden onset unilateral 4th nerve palsy in a healthy 40-year-old with no long-standing features and no head trauma. For the response no need, there were 4 scenarios, and these were blepharospasm in a 40-year-old. Second one was a spasm of the near reflex in a 40-year-old, suspected bilateral tobacco alcohol or nutritional amblyopia in a 40-year-old alcoholic, acute unilateral typical non-arthritic AION in a 65-year-old with hypertension. The conclusion was neuroophthalmologists differ on urgency of neuroimaging, with consensus for some neuroophthalmological cases and disagreement for many. To determine timing of the neuroimaging, furthermore prospective or retrospective studies need to be done. This attempt at assessing areas of consensus and disagreement regarding the urgency of new imaging in a neuroophthalmology is crucial for future decision making regarding neuroophthalmological cases. The principal weakness of this study is that it reports neuroophthalmologists' stated practice, which may be influenced by the recall bias. Audit of the actual practice shall be more accurate, but could be logistically difficult across so many hospitals. In addition, there have been many neuroophthalmic scenarios that were not addressed in the survey, and also the simplification of the scenarios is not genuinely reflective of real patients, where multiple additional clinical and the psychological factors play a part. Nevertheless, it could serve as a valid qualitative reflection of expert opinion in a controversial area where an adequate evidence base is lacking. These are my references. Thank you.